and I'm going to serve as moderator for today's webinar, which is going to focus on the guidelines for establishing and maintaining a successful antimicrobial stewardship program, and will include some best practices and case study metrics as well. This is an accredited CE course for pharmacists, and in order to receive CE credit, you must attend the full webinar, and when you registered, you needed to provide both your date of birth and your NABP e-profile ID number. If you did all that, the CE will be awarded in approximately 30 days, and if you need any assistance obtaining CE, the last slide of this presentation will contain the appropriate CompleteRx contact information. So all participants will be on mute throughout the webinar, but we certainly encourage you to submit your questions using the Q&A feature on your screen. There's also poll questions throughout today's discussion, and we appreciate everyone's active participation with those as well. So let's get started by introducing our two presenters. Julie Rubin is the Director of Clinical Services for CompleteRx. She has more than 15 years of pharmacy experience, is board certified in pharmacotherapy, and has held numerous positions at CompleteRx, including interim clinical manager and continuing education coordinator. Paul Green is a clinical manager for CompleteRx at a 2-hospital health system on the East Coast. He has 10 years of pharmacy experience with a focus on clinical pharmacy and continues to serve as a thought leader for antibiotic stewardship programs throughout the company. In addition to being board certified in pharmacotherapy, Paul has completed his Master's of Health Administration and the ASHP Pharmacy Leadership Academy. And with that, I'm going to turn it over to Julie Rubin to get us started.
Thank you. So at the conclusion of our discussion today, I hope you will be able to recognize the relationship between antimicrobial resistance on clinical and economic outcomes in various patient populations, outline the core elements required by Joint Commission in establishing and influencing the role of ASP, describe the various metrics used to measure antimicrobial utilization, and finally, to recommend clinical interventions for ASP that can be implemented in various pharmacy practice models. Both Dr. Green and I have nothing to disclose. This presentation reflects our experience with the topic at hand. All faculty and planners report no financial relationship to this activity. So we're going to begin with the question is, what is antimicrobial stewardship? It is a coordinated intervention designed to improve, measure the appropriate use of antimicrobials, which include antibiotics, antivirals, and antifungals. In simple terms, the ASP requires the right drug, the right time, the right amount, and the right duration. ASP has shown to reduce the development of multi-drug resistant organisms, adverse drug effects, hospital lengths of stay, collateral damage, and healthcare costs. We're going to open up with a poll question. What is the primary goal for implementing ASP? As you can see, everyone chose to improve patient outcomes, as you are right. Other goals and outcomes that you can actually look at include minimizing unintended consequences of antimicrobials, C. death, resistance, and adverse events. Some secondary outcomes that we all like to do is to reduce the healthcare costs without adversely impacting quality of care. Antimicrobial stewardship is a hot topic within many of our national societies and agencies. It is the first joint collaborative effort between pharmacy, medicine, infection control, microbiology, and information technology. The combination of rising rates of antimicrobial resistance and dwindling effective antimicrobial agents and increasing financial pressure for hospitals has spurred new interest in one intervention that can help prove these adverse outcomes. The interest is headed by CDC and SHIA. It is the first combined effort to tackle inpatient antimicrobial use and first to set quality metrics for its use. It was hoped to raise awareness to the growing issue. So why do we need antimicrobial stewardship programs? According to Thomas Friedman, Director of CDC, the pipeline of new antibiotics is nearly empty for the short term, and new drugs could be a decade away from discovery and for approval and by the FDA. There are many reasons for this reduction. First, between 1980 to 2000, mortality began to rise due to drug resistance. The mortality rate is influenced by the type and severity of the illnesses, but also the need for the expansion of new strategies to treat them. Secondly, there was a large gap in antibiotic discovery from 1962 with the fluoroquinolones to 2000 when linezolid was discovered. Lastly, drug companies are spending far less money on discovery of antibiotics. Antimicrobial resistance patterns is growing concern in public health. Through this chart, you can see there has been a shift from MRSA in our community for nosocomial, the dark black squares, to the light squares, the gray squares, which is community acquired. Approximately 2 million people are infected by resistant illnesses, and approximately 23,000 die. Resistance has crossed all the different spectrums of pathogens. There are many cases of anaerobes, gram-positive, gram-negative, and lastly, there are a few cases of fungal resistance. C. diff is a highly contagious infection causing diarrhea, loss of appetite, and abdominal pain. One of the main causes is due to increased use of antimicrobials. It is caused by the killing of our natural flora in our gut. It affects 250,000 annually, and it costs approximately $1 million. Like C. diff, MRSA is another resistant pathogen. It affects approximately 80,000 per year and costs approximately $60,000 per patient. It is naturally found in our skin. Approximately 30% are carried in our nasal passage. 2% is MRSA. It affects about 50% of our hospitalized patients. With the growing use of vancomycin and overuse, staff are becoming less susceptible, and now VRE, vancomycin-resistant enterococcus, is becoming well known. Acinetobacter is a common gram-negative opportunistic infection and is found in our soil, lung, and blood. It also has a high mortality. The prevalence has increased from about 4.2% to 7% in 2003. Recent pathogens have been found in most of our military hospitals, burn areas, and critical care units. And as time has progressed, the number of antimicrobials that could treat this type of infection is becoming diminished. So why do we need ASP? Because greater than 50% of all our inpatients receive antibiotics, and 50% of antibiotics prescribed are unnecessary and inappropriate. It lends itself to growing antibiotic resistance, more infections, prolonged illnesses, greater risk of death, higher health care expenditures, approximately $20 billion spent. As a result of the growing resistance, limited number of antibiotics, increasing issues facing our hospitals, the CDC, with the assistance of the White House, has developed an action plan to reduce inappropriate antibiotics by 50% in the outpatient and 20% in the inpatient by 2020. As of January 1st, 2017, Joint Commission requires that all hospitals seeking accreditation have an active ASP. CMS is also tracking ASP with the plans to tie it to real money, to ASP-related items in the near future. In 2015, when we looked at the average rate of which hospitals actually had an ASP program, it had about 49% across the country, highest being on both the East Coast and also on the West Coast, with the middle lagging behind. And again, the goal is 100% by 2020. Next, Dr. Paul Green will speak to the elements of ASP, types of interventions we are making, and finally, how we can track our success.
Thank you, Julie. Let's take a few minutes to discuss the highly interconnected and multidisciplinary team that makes up a successful antimicrobial stewardship program. The Joint Commission and IDSA provide guidance regarding what members of the hospital staff should be included on the ASP team, and their lists are remarkably similar. Both strongly recommend that every ASP should include representation from 4 specific groups. Those include providers, especially an infectious disease physician if available, clinical pharmacists, again ideally with IB training, an infection preventionist, and members of the C-suite. We'll look more closely at those roles in a moment, but first let's consider a few of the other groups who might go overlooked on the initial survey but can be vital to the success of your program. An optimal ASP includes strong representation from the IT department. In the modern healthcare system, being able to utilize your hospital's electronic medical record and computerized provider order entry system is imperative. Together, these systems can serve as the ultimate tool for antimicrobial stewardship by providing instantaneous surveillance, feedback, guidance, and education to various members of the healthcare team, including the providers who are ordering your antimicrobials. This is one of the many reasons that having a strong IT presence on your team is beneficial. They are critical to integrating stewardship protocols and policies into the hospital's existing workflow. IT can also assist with the development and monitoring of reports that pull data directly from your EMR for analysis and reporting on specific goals of your antimicrobial stewardship program, as is required to meet the Joint Commission standard. Another unsung hero of a good ASP is nursing. Nurses are by far the members of the healthcare team who spend the most time providing direct care to our patients. They also are the ones who administer the vast majority of the antimicrobial agents used in hospitals. These facts position them perfectly to serve as key members of the ASP by helping to monitor the fact that the medications are administered at the appropriate times, that no adverse reactions or side effects occur, and that pertinent labs are relayed to other members of the healthcare team who can act upon them. While there are certainly several other groups of note listed on this slide, the last one that we'll discuss for the moment is perhaps the most often overlooked: environmental services. The bacteria that are responsible for many of the most serious hospital-acquired infections, including C. diff, are often spread from person to person by the touching of contaminated inanimate environments such as linens, bed rails, tabletops, stethoscopes, and glucometers. Keeping these and other often touched surfaces clean and disinfected is of the utmost importance to the care of our patients, is a vital part of antimicrobial stewardship, and proves the need for including environmental services as part of our program. In 2014, the CDC released its checklist for core elements of hospital antibiotic stewardship programs. Much of the remainder of this presentation will explore those core elements and how addressing each of them can help establish a successful ASP that is prepared to meet the Joint Commission standards and future requirements of other governing bodies. In brief, these core elements include a formal leadership commitment, including allowances for staff to have dedicated time and resources necessary to participate fully in the ASP. Part of this participation should include the services of a drug expert, namely a clinical pharmacist, to serve as one of the program's leaders. Perhaps the most important aspect of any successful program is educating staff at all levels, not just providers, to what the goals and methods of the program will be and how they can help it to succeed. Once those goals have been determined by the ASP leadership, specific action must be taken to implement a plan. That action must then be monitored and reported upon on a regular basis. The ASP leaders must also be accountable for the outcomes of the plan that they implement. While they might not be initially successful, they must be able to gain insight from the data gathered and adjust future plans accordingly. Next, we'll dig deeper into a few of these important core elements. The executive leadership of the health system must establish antimicrobial stewardship as an organizational priority. all of the major guidelines on the subject concur that there must be a formal expression of support for the ASP made by administration. Examples of these leadership commitments include accountability documents, budgets, infection prevention or performance improvement plans, or even something as simple as a letter of support from the C-suite specifically endorsing the ASP and encouraging that stewardship-related duties are important and staff should be allotted time needed to properly take an active role. Also, these ASP activities should be included in such items as job descriptions and annual performance reviews. Beyond the C-suite commitment and oversight, the ASP itself needs to have a strong designated leader. Given that the ordering of antimicrobial medications is a medical staff function, the leadership role traditionally falls to a physician. Ideally, that physician would be an infectious disease specialist, but that's certainly not possible in all healthcare settings. Of note, even a part-time consultant or telehealth ID doctor is considered to be an acceptable member of the ASP team. In the absence of such a specialist, any member of the medical staff with the drive and interest to tackle this important role would be welcome. This program leader will serve as the accountable party for the outcomes of the ASP. They will also be important for peer-to-peer discussions that are needed amongst members of the medical staff. Beyond that, they will be active in order set development, making formulary recommendations, approving reserved antimicrobials, and educating both other members of the healthcare team, patients, and their caregivers. In addition to having a leader from the medical staff, identifying a single pharmacy leader who can co-lead the ASP is essential. As the medication expert on the team, the pharmacist can play a vital role by helping to promote and monitor the optimal use of antimicrobials. The clinical pharmacist can also share in all of the duties and responsibilities that were discussed as part of the role of the physician leader, including the ever-present need to educate health professionals, patients, and the public about the important issues of antimicrobial stewardship and infection prevention. Given that all medication orders must be reviewed by a pharmacist, they are ideally positioned to oversee restriction policies that require approval for the use of certain agents. In coordination with those efforts, the pharmacist can also encourage appropriate substitution of an antimicrobial to an agent which is considered to be therapeutically equivalent, while being perhaps more targeted to the specific infection being treated or even more cost-effective. The pharmacy department is also closely tied to the purchasing plans and group buying agreements through which the health system purchases their antimicrobials, and may be able to work in that aspect to obtain competitive pricing. Okay, now it's time for our next quick poll question. All of the following are part of the core elements of ASP except all right, looks great. The majority of everyone got the fact that the core elements did not specifically include the fact that the program must be led by a pharmacist. They just encourage that the pharmacist be a member of the team and can serve as a co-leader. We've already touched on the next topic several times, but its importance cannot be overlooked. In fact, the Joint Commission dedicates 2 entire ASP elements performance to the education of not only the staff who order and interact with antimicrobials, but the patients who have received them and their caregivers. As the prescribers, it is vital that clinicians are fully engaged in and supportive of efforts to improve antimicrobial use in the healthcare system. However, as anyone who's ever attempted to do so knows well, changing prescriber practices and habits can be challenging, to say the least. Education to these ends can take many forms. Often feedback from patients or peers can be helpful, as can reminders related to current guidelines and best practices. Perhaps most important is reassuring providers that the goal of the Antimicrobial Stewardship Program is not to restrict in any way their practice of medicine, but instead to optimize it. Education establishes the foundation for buy-in from providers, and it should occur upon hire or granting of initial privileges and periodically thereafter, often with yearly updates. Now let's explore what items new antimicrobial stewardship programs can dig their teeth into in an effort to start making measurable impact on their healthcare system. There are two basic methods by which antimicrobial stewardship interventions are classified. Those that occur before the medication is ordered, here delineated on the left-hand side of the graphic, and those that come afterward, which are shown on the right. The cornerstone of the front end or pre-order philosophy of stewardship is that of antimicrobial restriction. This is the practice by which antimicrobials that are particularly high cost or broad spectrum, meaning that they kill the widest variety of bacteria and therefore also commonly have the largest risk of adverse events, are kept out of use by stopping providers from being able to order them in the first place. The items are either not included on the formulary or have very specific criteria established which must be met before the restricted agent can be utilized. These restrictions will, however, then shift your ordering practices to other unrestricted agents, which will necessitate ensuring that any and all antimicrobials ordered are being used appropriately. Of note, some healthcare systems have chosen to avoid the potentially off-putting connotation of the word restricted by listing the medications that they wish to prevent use of as either protected or reserved, which may be more palatable to providers who are new to the practices of antimicrobial stewardship. The opposing ASP philosophy takes place on the back end of the order with prospective audit and feedback. In this method, an ID-trained provider or clinical pharmacist will review the record of the patients who are currently receiving antimicrobial therapy and assess whether improvements can be made. This can certainly be a highly effective method by which to decrease the inappropriate use of antimicrobials, but the downside is that it's very time-intensive for the healthcare professionals who are performing the audits and recommending the changes. In the end, most healthcare systems end up using a combination of these two philosophies. Let's further examine some of the specific elements of these practices that should be considered and prioritized. Perhaps one of the simplest interventions for a new ASP to start on is formalizing a process for automatically converting appropriate patients who are receiving parenteral or IV antimicrobials to oral or PO therapy. In their guidelines for the treatment of community-acquired pneumonia, the IDSA outlines the gold standard for establishing which patients are appropriate for such an IV to PO conversion. Obviously, the patient needs to be able to be tolerating oral intake, and they also need to show signs of clinical improvement before performing such an interchange. However, once the criteria are established and educated upon, this task of conversion can be easily undertaken by a pharmacist through following a policy and procedure approved by the medical staff, thereby negating the need to contact the provider for an order when the patient meets criteria for an approved interchange. By transitioning these patients to oral therapy, studies have shown that we are able to decrease overall length of stay and healthcare costs, since oral medications can often be taken at home and tend to be less expensive than their IV counterparts. Next, we come to two of the cornerstones of antimicrobial stewardship that are also key functions that can be overseen by clinical pharmacists through the implementation of strong policies and procedures. Antimicrobial streamlining, also known as de-escalation, is the process by which the provider or pharmacist takes into account the finalized culture and sensitivity data for the patient, as well as many patient-specific factors, including age, weight, and renal function. Once that information is known, the ASP team can determine if the current treatment regimen should be continued as is, or if it can be narrowed to a more targeted single agent in an effort to decrease exposure to broad-spectrum antimicrobials, which may lead to increased adverse events and even worsening of the local drug resistance patterns. A side benefit of streamlining therapy can be the potential for cost savings in addition to the many clinical benefits. Antimicrobial streamlining has the advantage of allowing providers to empirically utilize broad-spectrum therapy with the understanding that once culture data are back, a narrowing to a more specific targeted agent will occur. One disadvantage that can be encountered, however, is that providers sometimes are reluctant to change away from the broad-spectrum therapy on which the patient is clinically improving. This provides an excellent opportunity for one-on-one education of the provider with regard to the benefits of the practices of antimicrobial stewardship. Dose optimization takes a different approach and is characterized by ensuring that the patient is receiving the specifically tailored dose of a medication that is appropriate for the type of infection they have and the ability of their body to metabolize the medication with which they are being treated. Again, the key pharmacokinetic and pharmacodynamic parameters are taken into account as they were with antimicrobial streamlining. Once these have been assessed, the provider or pharmacist can devise an appropriate treatment regimen that the patient will include an optimal dose. Time again for a quick poll. The advantages of de-escalation of antimicrobial therapy include which of the following? All right, again, almost everyone got the correct answer, which is all the above. De-escalation of antimicrobial therapy is a process that will decrease inappropriate use of antimicrobials, narrow therapy when appropriate, potentially decrease adverse events, and allow for use of initial broad-spectrum antimicrobials. In order to have an effective antimicrobial streamlining process, you must have good practices in your lab, specifically the microbiology department. The health system should enact procedures to ensure that appropriate cultures are obtained prior to antimicrobials being administered in order to avoid those first doses from killing off initial waves of bacteria that would have otherwise grown well in culture, leading to the ability for more targeted treatment to be used later. Beyond simply developing processes by which cultures are properly and promptly ordered, obtained, and processed, the microbiology department must also be able to ensure that this important information is disseminated to the appropriate healthcare professional who can act upon it in order to support optimal antimicrobial use. The microbiology department is also key to gathering data for the development of the health system's antibiogram, which denotes specific antimicrobial susceptibility to agents as a result of the institution's culture data and allows providers to more accurately select the empiric antimicrobials that are most likely to target the predominant pathogens in their organization. We've talked at length now about the importance of education and active intervention with regard to antimicrobial stewardship. One final opportunity for education that we haven't touched on, though, occurs at the moment when the provider is actually placing the order for the medication. By utilizing current guidelines and best practices, along with interprofessional input from the ASP team and others, site-specific guidelines and clinical pathways can be developed and incorporated into the CPOE system. These documents often take the form of order sets, which direct the provider to choose the medication that is most appropriate for the specific patient being treated. In the age of optimizing electronic medical records, these pathways also provide an opportunity to tie in key pieces of information, such as labs and cultures, that may also aid the provider in making their clinical decisions. We just discussed the importance of electronic methods for improving antimicrobial stewardship through CPOE systems, but the need for paper order forms that mirror those practices cannot be overlooked, even if they are only utilized during specific downtime procedures. While we've now discussed numerous methods that are recommended to improve antimicrobial use, I wanted to take a moment to address two that are to be avoided. Utilizing combinations of antimicrobials in an effort to ensure adequate coverage of a given microbe has fallen out of favor in the last several years. Historically, this practice was used to increase the odds of appropriate treatment until solid culture data were available, but it's now been shown to increase the risk of adverse events and antimicrobial resistance, and should only be used in very specific instances for patients that are at high risk for multi-drug resistant organisms. Likewise, the practice of antimicrobial cycling has also gone out of vogue because of insufficient data to suggest that it had any long-term benefits. In short, this was the practice of utilizing one specific agent on formulary to cover a class of bacteria, and then switching the formulary agent to another medication after a predetermined amount of time, with the thought that by giving each agent a year or two of rest, susceptibility patterns would have time to improve. Again, in the long run, this has not been shown to be the case, and this practice is no longer recommended. Finally, we come to an antimicrobial stewardship practice that ties together the core elements that we've been discussing. The antimicrobial timeout is a process where after a patient has been receiving an antimicrobial for a predetermined amount of time, usually either 48 or 72 hours, which is enough time for at least initial culture and lab data to have resulted, the provider and other members of the ASP team take a moment to stop and consider if the current therapy is appropriate and should be continued, or if changes need to be made. First, they must determine if the patient even has an infection that will respond to antimicrobials. If they do, they must then go on to decide if the patient is on the most appropriate antimicrobial, including the best dose and route of administration. The team should consider if they could now streamline therapy to a narrower, more targeted antimicrobial, or transition from IV to oral therapy. They must then establish what the total amount of time the patient will be treated for is. Finally, they must clearly document their decision so that other members of the healthcare team understand what's being done. All right, time for our final quick poll question. What steps are included in microbial timeout? All right, it looks like, again, the majority of people chose the correct answer, which is that an antibiotic timeout includes reevaluating the patient who has been receiving antibiotics for greater than 48 hours. Again, greater than 72 hours would also be appropriate time frame. Now that we better understand what actions can be taken as part of an antimicrobial stewardship program, we need to determine some best practices for monitoring our progress towards our goals. We've mentioned several of these specific items throughout the presentation, but the measurement of outcomes can be broken down into 4 main categories: clinical, process, economic, and humanistic. For the sake of time and simplicity, let's explore the one that you're most likely to encounter soon in needing to report data to agencies such as CMS, namely antimicrobial utilization tracking by way of days of therapy. Understanding days of therapy, or DOT, can be a bit confusing at first, so let's break it down as simply as we can. By definition, 1 day of therapy is the administration of at least 1 dose of a specific agent on a specific day. This is regardless of the number of doses that are actually administered or the strength of those doses. Unlike other common methods for measuring drug utilization, such as defined daily doses, the days of therapy method can be used in pediatrics and is not thrown off by patients who may have had their doses optimized for their renal function. DOTs are simply looking at the days of exposure to the medication in question. Days of therapy are also often adjusted for hospital census by dividing them by a specific volume, such as 10,000 patient days. Let's walk through this simple example of how to determine days of therapy. The patient is receiving 1 gram of vancomycin every 12 hours for 5 days. The fact that the patient is getting more than 1 dose per day is irrelevant for the calculation of days of therapy. All that we're concerned about is how many days did the patient receive at least 1 dose. The patient was on vancomycin for a total of 5 days, which therefore gives us a DOT of 5. Again, it is strongly predicted that this DOT method is the one that will be utilized by CMS and other government agencies when they begin their formal tracking of antimicrobial utilization and stewardship programs in the coming years. We've shown who needs to be involved in a strong ASP, the practices that should be implemented, and some of the methods by which to monitor those practices. Now let's examine a great example of someone who's getting it right. This hospital began planning its ASP in the spring of 2015. They chartered a formal subcommittee through P&T and began meeting over the summer of that same year. And by the fall, they determined that their first target for improvement would be their rising hospital onset C. diff rate. This graph serves as a before picture. The gold line at the 11.2 mark illustrates the national benchmark for number of cases of hospital onset C. diff per 10,000 patient days. As you can see, the hospital was having a very hard time staying below benchmark with any consistency, and as they moved through 2015, any little success that they had been having was wiped away by a large spike in cases. So the newly formed Antimicrobial Stewardship Program decided to tackle the issue in a multifaceted manner. First, they implemented new system-wide CPOE order sets for the treatment of C. diff when it did arise to ensure that patients were receiving optimal care and would have less likelihood of relapsing. They also restricted the use of oral vancomycin, which is a broader spectrum agent that can be used for the treatment of C. diff, but is only recommended by the IDSA to be used in severe cases. As part of this restriction, they also granted pharmacists the ability to therapeutically interchange any patient who has ordered an inappropriate treatment for C. diff to the guideline-recommended therapy through the use of a medical staff-approved protocol, thereby removing the need to contact the provider before making the change. In addition to these C. diff-specific changes, the ASP also worked to establish a 72-hour antimicrobial timeout process that encouraged antimicrobial streamlining. All these new practices were accompanied by multimodal education campaign that reached out to all corners of the healthcare system. This is an example of the C. diff treatment protocol that was implemented. As you can see, in keeping with current best practice recommendations, it delineates the patients into mild to moderate or severe, as well as to whether they're an initial case or a recurrence. Again, if the providers inadvertently ordered a therapy that did not fit this protocol, the pharmacists were approved to automatically transition the patient to the most appropriate treatment. As you can see, this graph showing the aftermath of the process looks much better than the one that was shown a few moments ago. Since the ASP implemented their C. diff targeted program, the rate of hospital onset C. diff infections has remained below benchmark every quarter. Obviously, not all initial attempts at making an improvement by a new ASP are this successful in such a short amount of time, but this is certainly something to shoot for.
I also believe that with his education plan to the physicians, nursing, and pharmacy staff, he gave them the tools to answer the questions proactively, and the therapeutic interchange step and tool allowed those pharmacists to be very proactive, stopping it immediately, not having to interact with those physicians, and in order to gain this success that he had with this program.
Absolutely, Julie. So in conclusion, what are the key pieces that we'd like you to take away from this presentation? First, CMS and Joint Commission are actively developing and implementing standards related to demonstrating that every hospital has an effective antimicrobial stewardship program. Many of the items that they're looking at are already being tracked and publicly reportable, and more are moving that way in the future. It's my hope that you also now understand that this is a serious and urgent issue related to both public health and patient safety. You need to take an active interest in what's going on in the communities in which you live and work and encourage others to do the same. Finally, please understand that implementing an antimicrobial stewardship program is not something that happens overnight. It's the process. You don't have to implement everything at once. You can take the slow and steady approach as long as you keep moving forward. Every institution is different and every ASP is unique. The core elements that we've discussed are the same for every healthcare system and should be used to guide your initial steps as you work towards your goals. Every member of the healthcare team, from the C-suite to the folks in environmental services, need to be involved, supportive, invested in the important aspect of patient care that will result from a successful implementation of your antimicrobial stewardship program.
Like Paul said, whether you're just starting or in the middle of implementing ASP, it could be quite daunting. Conducting quarterly gap analysis with goals in mind, allowing you to see your progress and areas of weaknesses is key. If you are just beginning, start with some of the easy tasks, policy, IV to PO, lay the foundation with good education. Next, allow that team that you've built to choose a list from and tackle in that special order. Examples include the timeout, indications, and restrictions. Keep in mind, always report progress, identified metrics back to key stakeholders to keep them engaged. Finally, we can encourage you to create a binder with all your policies, letters of intent, scorecards, interventions, in order to be prepared for that Joint Commission visit.
Okay, with that, that concludes our formal, PowerPoint presentation. We want to thank both of our presenters, Julie Rubin and Paul Green. And we do have some questions. Just a reminder, if you'd like to ask a question, just go to the question feature through the webinar. And then before we answer those questions, though, just one quick note, there is a very short 2-question survey following the program. So we want to thank you in advance for completing it and providing your very valuable feedback to our webinar today. We also want to mention here that you're going to receive an email with links to download the webinar recording and slides, and you can also email us at the email address on the screen for more information or questions regarding CE. So with that, we'll go ahead and start our Q&A session. And one of the first questions is, what are some of the other metrics that sites are using to track ASP?
That's a good question. Some of the other metrics that people can actually use is look at the drug expenditures, the cost, the length of stay, picking C. diff rates and other resistant organisms and see how you can tackle those. So any of those and any method could help prove or disprove on your successes in ASP.
Okay, and then our next question is very specific to prescribers. So a lot of them are really worried about the automatic switches to oral therapy, and then also how it affects admission status. And then there's insurance companies that are denying based on the patient's ability to switch to oral therapy. So how should this person respond to those two issues?
Another good question. I believe in many cases, if you can actually show there's other disease processes or other issues that you're monitoring, not necessarily the IV to PO, you can continue in hospital during that stay. They're looking at everything, just not that one therapy, and you should be able to look at the whole entire picture to keep that patient. It used to be a false kind of thought that this would actually happen. I actually think it's not happening as much as people believe now in the future.
Yeah, I very much agree with Julie there. And if the only reason the patient was in the hospital was to be receiving those antibiotics and IV therapy was determined by the guidance of the IDSA to not be appropriate, then maybe the person should be transitioned to home or to another setting at that point.
Okay, and then what are some of the successes that you've seen specifically with ASP outside of what obviously has already been mentioned in the presentation today?
I think that with many of the programs, places that have actually started the extended spectrum antimicrobials, you'll see anywhere between a 25 to 30% reduction in use as well as cost, which is very nice for exposure. It decreased, and it's also helped with resistance patterns. We are also seeing a lot of patients being switched more effectively to the appropriate therapy, and also physicians utilizing those pharmacists as that key stakeholder in making those initial decisions. So we're becoming part of that big team.
Absolutely, and ensuring that our patients are getting the appropriate treatment for the infections that they have is also going to help with things like your readmission rates that are so on everyone's mind at this point.
All right, and then we've already had one here, but are there some other common roadblocks to implementing an ASP?
I can say in developing my programs, the one that I run into the most is just time in the day. Being able to free up the members of the team in order to do the activities that they need to, in addition to all the other things that they're called upon to do in their daily work. So just being able to either find a way to afford one specific person to be able to look at those tasks or spread the tasks out in an efficient manner amongst many people. There's different ways to overcome that one, but that's been the primary one that I've run into several times.
And I think I would actually go right along with Paul and say that there's been a lack of consistency. I think they think that if they don't have that ID physician, that one physician to be that key stakeholder, they think they can't run that program. Pharmacy is a great advocate. They need to lean on us more, use us more, and I like the idea of having that telemedicine consult or that consult from far away. I think they can utilize us more in those decisions. And we're becoming one of those key stakeholders.
Yeah, that's a really good point. It's not just one person.
No, it's a group.
One individual, one specialty. Okay, well, we want to be really respectful of everyone's time here, so we're going to conclude today's webinar. On behalf of the CompleteRx team, we hope the program was really helpful, and we thank you again for your participation. If you have any additional questions, please don't hesitate to reach out via the email on this screen. And with that, I hope you all have a wonderful afternoon, and we'll sign off.